This section is a more advanced section on nutritional assessment, specifically dedicated to blood biochemistry and aimed specifically at protein malnutrition and anemia. Now, as part of the nutritional assessment aspect, let's look at laboratory tests. Using blood and urine samples, clinicians can pick up on early signs of deficiencies. We call these subclinical findings. For instance, a low serum ferritin, which is measured as an early stage of iron deficiency anemia or iron depletion, is a subclinical indicator for which there's no physical signs available of a deficiency taking place, making it covert as a sign. So a subclinical sign, which is an early sign that precedes the more elaborate and the more visible sign, is oftentimes covert, hidden away, as opposed to overt, which is very much available and visible, if you will. So let's take a closer look at protein energy malnutrition, and using laboratory tests, let's figure out what's reliable and unreliable. Well, first of all, serum albumin is certainly unreliable. The serum albumin does not reflect generally the state of protein malnutrition. Its half-life as a protein is quite extensive, quite long, so it takes a long time to react to the conditions of malnutrition. So you can't really rely on serum albumin for protein malnutrition, but we do rely on albumin as a prognostic indicator of morbidity. Now, serum transferrin is a pretty good indicator for iron. It has a tendency to increase in order to accommodate, of course, grabbing as many iron atoms as potentially can. So when the iron reserves are low, serum transferrin will tend to increase. Now, this is important to note because at the same time, serum transferrin, in the absence of iron deficiency anemia, is actually susceptible and sensitive to protein status. In other words, when iron stores are relatively stable and relatively full, the serum transferrin in the state of protein energy malnutrition will actually go down. Whereas in iron deficiency anemia, it will go up. So that's an important distinction to remember. The other thing is that serum retinol binding protein is also an indicator both of vitamin A status, but also of protein status. So what we see with serum retinol binding protein in a state of malnutrition, of protein malnutrition specifically, with a vitamin A status that's adequate, we see a drop or a fall in retinol binding protein. When we see a vitamin A deficiency, we also see a drop in retinol binding protein. So a drop in retinol binding protein, before it can be used as an indicator of protein status, it's important to rule out that there's no vitamin A or retinol deficiency taking place. Now, serum transthyretin, or otherwise known as prealbumin, is a reliable short-term indicator of protein status, and so it is used in these particular circumstances. Also, insulin growth factor, IGF-1, is also a reliable indicator of protein status. So it's important to remember this, so I'd recommend that students know these basic principles cold. I'd like to review a few pointers regarding iron deficiency anemia. First, serum ferritin. You must understand that serum ferritin occurs in the first phase of depletion, and this is the phase of early depletion of iron stores. So a low serum ferritin is not an iron deficiency anemia, it's a pre-phase, indicating that the stores of iron are on their way down, but they haven't quite hit iron deficiency anemia. If you remember the three phases to that table, and when it hits iron deficiency anemia, it's usually in the third phase of depletion. And this is where you see transferrin saturation decrease, and this is where you see erythrocyte protoporphyrin actually increase. And again, why does the protoporphyrin, erythrocyte protoporphyrin, increase? It's because the erythrocyte protoporphyrin requires iron in order to become hemoglobin. So if there's insufficient iron, either in the reserves or released into the blood, as in the case of anemia of chronic disease, the protoporphyrin cannot combine with the appropriate number of iron and become hemoglobin, so therefore protoporphyrin levels actually increase. And this is the reason why we see erythrocyte protoporphyrin increase in concentration in the examples of anemia of chronic disease and also in iron deficiency anemia. And again, finally, transferrin saturation decreases because there is less saturation of the available transport sites on transferrin. And the reason for this is because there's a lack of iron. So consequently, the saturation levels actually decrease. Continuing on with the subject of nutritional deficiencies, let's take a closer look now at folate deficiency anemia. So you need to know these three aspects cold. First, serum folate occurs with low folate intake. It's actually very sensitive to the actual recency of folate intake. So even though erythrocyte folate tends to be less sensitive to short-term intakes of folate, it is, however, more reflective of a storage and status level of folate. Now we have to keep in mind, and I ask students to review page 258 in terms of the intricacies that have to be considered with erythrocyte folate, that erythrocyte folate alone cannot absolutely conclude that there's a low folate because it's not specific. It also decreases, for example, in B12 deficiencies. So there are other subtleties here, and I'll invite students to read about them. But we can certainly say that it can be used as an indicator of the long-term storage status of folate as opposed to the recency of intake, which we see with serum folate. Now, if serum folate concentrations, even though they vary with recency of intake, if they fall below the cutoff of 3 nanograms per milliliter, it tends to correlate with low folate storage and to a folate deficiency. Now, when there is a folate deficiency, we can assume then to expect an elevation or a rise in MCV, mean corpuscular volume. And this represents megaloblastosis or a large red blood cell. So this is called megaloblastic anemia due to a folate deficiency. Now, we also know that this folate deficiency or this large red blood cell can occur also because of a B12 deficiency, which, if not present, will not activate the folate, and therefore we still end up with a megaloblastic anemia. So MCV can occur due to a folate deficiency. It can also occur due to a B12 deficiency, and it can occur also due to both folate and B12 deficiency. So here's a review of the pathways that demonstrate that both folate and B12 deficiency can act together or separately in causing macrocytosis or megaloblastosis, large red blood cells. So what we see in this graph is the enzyme methionine synthetase receiving the methyl group from the donor 5-methyl tetrahydrofolate and transfers it to the cobalamin for the generation of methylcobalamin. This methylcobalamin then orchestrates the demethylation, if you will, or the activation of methyl tetrahydrofolate to tetrahydrofolate, which is the active form of folate, and as you can see with the arrow going down, used in DNA synthesis, which facilitates mitotic divisions. Now, because the inactive methyl tetrahydrofolate requires homocysteine in order to become demethylated and active, it's understandable that in a folate deficiency, there is obviously a buildup in homocysteine. So now what we understand from this particular graph is that the activity of methionine synthetase actually requires adequate amounts of cobalamin. So therefore, in the absence of cobalamin, or vitamin B12, we can see the reaction of homocysteine moving towards methionine getting hindered, and therefore leading to an increase in homocysteine as a result of a B12 deficiency. Now, also, we can reason that if there is a high homocysteine, but that the dietary folate is quite normal, and the serum folate is normal or elevated, we can conclude from this that there is probably a B12 deficiency. Indeed, when serum folate is actually measured in the blood, its measurement is a reflection of the methyl tetrahydrofolate. So if somebody's folate levels in the blood, or their serum folate specifically, is elevated or normal, that suggests that their recent intake of folate has actually been quite good. If it tends to be elevated, it's usually the consequence of not being able to get transferred to its active form, tetrahydrofolate. Consequently, we not only see normal to high homocysteine, but we also see normal to high methyl tetrahydrofolate or serum folate levels in the blood. Now, also, if we see that serum folate levels are under 3 micrograms per liter, that tends to signify that the folate storage is so low that we can infer generally a deficiency in folate, and that would tend to be associated with large red blood cells or a megaloblastic anemia. Now, that will also tend to be associated with a low dietary folate intake as well, if we did something like that in a 24-hour recall or a 3-day record. Now, it's really important to point out here that a folate deficiency alone is usually associated with megaloblastosis. There can also be a B12 deficiency taking place. We can see that as well as we go over this graph. However, a B12 deficiency, even though it can cause both megaloblastosis and the neurological degeneration associated with pernicious anemia, a folate deficiency alone can only cause megaloblastosis. So what we learned is that folic acid supplementation, which is the active form of folate that's added in the fortification of the food supply, sometimes can mask a B12 deficiency. So here's the reasoning for this kind of conclusion. When a physician sees that there's megaloblastosis in a blood smear for a patient, he asks basically 3 questions. Are the large red blood cells due to folate deficiency? Are they due to B12 deficiency, or are they due to both? And you could also say there's another question whether or not it's due to a non-nutritional cause as well. So, in asking these questions, the physician is basically recognizing the possibility of a B12 deficiency. But in a food supply that has folic acid fortifying the food supply, and folic acid is already active, then B12 is no longer necessary to activate it. Consequently, what we see is less megaloblastosis taking place, or less large red blood cells. In the absence of the prevalence of large red blood cells in the population, the physician is asking less and less whether or not there's a B12 deficiency, because the large red blood cell is no longer there as a possible reason for questioning that possibility. So we say, therefore, that fortifying the food supply with folic acid can actually mask B12 deficiency. Now, this is also a reality because B12 deficiencies usually take 5 to 10 years to occur because of the recirculation of B12 in our GI tract through the enterohepatic circulation. So consequently, we reutilize a lot of our B12 rather than secreting it in the urine or in the feces, as in the case of other vitamins. So, because B12 deficiency eventually leads to pernicious anemia, which is really the neurological degeneration that we talked about earlier on, and because B12 deficiency takes so long to occur, it usually falls out of the scope of interest of the physician and consequently gets masked in that way as well. So now let's move on and look at B12 deficiency specifically. Serum vitamin B12 is of particular interest because a deficiency value can be concluded when the serum values drop beneath 150 picograms per milliliter. So in this case, there's a higher reliability that a deficiency is actually taking place. Now, the Schilling's test is really a test of absorption. It's not a test to confirm B12. Schilling's test is usually done after a B12 deficiency has been confirmed, either through methylmalonic acid or a very low serum vitamin B12, or also using homocysteine, as we saw earlier. So this is how to interpret the Schilling's test. So if there's a decrease in the secretion of B12 in the urine, with the administration of an intrinsic factor, it basically confirms that there was initially insufficient intrinsic factor in the system, therefore confirming that there was a decreased absorption taking place. That would be explaining why there was a B12 deficiency. Again, the Schilling's test is not used to confirm a B12 deficiency, but rather why is there a B12 deficiency, and it's really verifying it here at the level of the absorption, if you will, of B12 in the gastrointestinal tract, the level of the ileum. Now, methylmalonic acid is another, of course, metabolite that's looked at, and it tends to go up in the serum and also in the urine in the cases of B12 deficiency. So I encourage students to read more about the Schilling's tests and the limitations of the Schilling tests, as well about the modified food Schilling tests on page 255 of the second edition of the textbook. Now, the methylmalonic acid pathway right here indicates the role of adenosylcobalamin in the transformation reaction of methylmalonyl-CoA to succinyl-CoA. And we can see then, theoretically, in the absence of a B12, that the reaction methylmalonyl to succinyl doesn't occur, which ends up in a buildup, if you will, of methylmalonic acid in the blood and also in the urine. So what does this mean? Well, first, MMA then tends to be elevated only in B12 deficiency. We don't see the role of folic acid at all in this reaction. So when MMA goes up, it invariably means that there's a B12 deficiency. So this measurement then can be used to distinguish between B12 and a folate deficiency. So imagine, if you will, that the serum folate is below that required cutoff to indicate that the reserves of folate are quite low. Imagine as well that homocysteine serum levels are actually also elevated. So when we look at this, we're not quite sure if there's a B12 deficiency also involved, right? There could be both a folate and a B12, because we understand that when there's a B12 deficiency, there can also be a rise in homocysteine. So we use the methylmalonic acid to help distinguish, to see, to tease out from that conundrum if there is a B12 deficiency going on as well, which would explain, of course, the rise in methylmalonic acid and the rise in also homocysteine. So now, having finished the blood biochemical signs in a nutritional assessment, looking specifically here in the case that we just saw, anemia, different types of nutritional anemias, we can now look towards the physical signs. And I just want to remind you that, hair texture, for example, symptoms in the eyes like a pale conjunctiva, symptoms around the mouth like a angular stomatitis, chelosis, which is the edematous lips, symptoms of the tongue, such as glossitis, and also signs in the skin, such as dermatitis, and in the nails, like the spoon nails in basically iron deficiency anemia, all become physical signs that are useful to help confirm, along with the blood parameters, that there is a specific diagnosis. Next question. Looking at the lab results of a patient, the clinician observes an elevated MCV, therefore suspecting either a vitamin B12 or folate deficiency or both. What lab test can be ordered to help confirm a B12 deficiency if a 3-day dietary mean folate intake equals 34% of the DRI? Pause here and select your answer. The correct answer would be E, methylmalonic acid. Here's the reasoning. Since the dietary recall indicates that the folate intake is 34% of the DRI, it sort of suggests that the serum folate would actually be pretty low. It suggests also the possibility of a folate deficiency, and we know the folate deficiency would also rise serum homocysteine. So the only other alternative that is distinctly reflective of a B12 status would be methylmalonic acid. Next question. A patient's lab indicates elevated MCV and an elevated serum homocysteine, low hemoglobin, and high erythrocyte protoporphyrin, in addition to a diet assessment indicating 85% of the RDA for folate. What can the clinician conclude? Pause here and select your answer. With the limited blood tests done, the clinician can conclude B, a B12 deficiency and an iron deficiency anemia. So let's examine the reasoning. Well, first, we can say that the elevated MCV and the elevated serum homocysteine would suggest the possibility of a folate deficiency and maybe a B12 deficiency. The diet assessment indicating that the patient's consuming 85% of their RDA for folate would suggest that the folate intake overall is likely okay. This is because the intake was not under 66% of the RDA. Had the intake been less than 66% of the RDA, we could say that there was probably a high probability that overall folate intake was suboptimal, but this is not the case. So there's no reason to suspect a primary deficiency of folate. Now, the evidence we have is also that with low hemoglobin and an elevated erythrocyte protoporphyrin, that we have the likelihood of iron deficiency anemia. Now, we have MCV, which normally would be small or reduced in iron deficiency anemia, but we have to realize that we are likely dealing with B12 deficiency leading to a megaloblastosis. So this MCV, rather than being small to reflect an iron deficiency anemia, is going to be slightly elevated. Probably not as elevated as if it was a pure B12 or folate deficiency without iron deficiency. So we have to realize here that the MCV is getting camouflaged, is camouflaging a little bit of the reality here. But we do have elevated EP and we do have a low hemoglobin suggesting a third stage iron deficiency anemia.